All right, it's recording.
Right. Do you want to go ahead and do the introductions?
Yeah. Good evening, brothers. Brother Nichols, Great Lakes Regional Director of Social Action. Thank you for joining this very informative topic as we talk about chronic kidney disease and its effects on not just the body, but how it affects you psychologically. And so we just wanted to get started. I'd first like to introduce Dr. Spears, the head of the Great Lakes Region Health and Wellness Committee, as well as, are you a co-chair of the International Committee, Dr.
Yes,
Spears?
sir.
All right, co-chair of the International Health and Wellness Committee, to just give you a basic overview of chronic kidney disease, and then we'll move into Brother Dr. Antoine Jenkins to give an overview of the from the pharmaceutical side of it, drugs that can lead to and cause kidney issues, and then we'll follow up and conclude with Dr. Brinson, who will go over the psychological effects of being diagnosed with chronic kidney disease. So we'll move right on. Dr. Spears.
Yes, sir. I'm going to share my screen. This first slide really just an introduction. So one of the things that we want to do is define what is chronic kidney disease. And we in the medical profession will say that chronic kidney disease is when there's derangement of kidney function that's lasted 3 to 4 months in duration. Okay. And so when you get that, that just means we need to look deeper into what caused it. Okay. Let's do this. So you all know who I am. So I'm going to skip that. So chronic kidney disease, there are several factors that can lead to kidney damage or decreased kidney function. And that includes diabetes, high blood pressure. There are some rheumatological illnesses such as lupus and scleroderma, rheumatoid arthritis. Medications can lead to changes that are consistent with chronic kidney disease. There are also changes that can occur from what we call interstitial kidney disease, which is something with the bladder, such as a cancer or some type of obstruction to the outflow of urine. So there are many things that can do that, that can affect your kidneys. So from my perspective, one of the things that I want everyone on this call and those who are going to come before to kind of understand where doctors get that information from, or we say before we tell you you have chronic kidney disease or you have kidney failure, right? And I want to make sure that when you look at certain data, because that data is always readily available to you if you have electronic medical records, or your doctor has electronic medical records like Epic, where you can get on LiveWell. Some people have MyChart, things of that nature. So you could see your lab tests. So I want you to know where to go to look for this information. Or when you look at it, typically because you'll see it before your doctor will, okay? I know that's how it is in my office. And I want you to be able to be familiar. I'm not trying to make anybody into a medical student or a doctor, and certainly not a nurse, but I want you to be familiar with that. So what I'm going to do is I'm going to start with something called a comprehensive metabolic profile. And here is where we draw all the information that we're going to use and talk to you. So in my office, I typically try to, when I order this test on someone and I give them their results, if they're all normal, I'll say either your blood chemistry is normal, or if I have somebody who I know is a little bit nervous about coming to the doctor, I'll start the conversation with your electrolytes, your glucose, and your liver and kidney functions are normal. But most people don't know what the electrolytes are, or what kidney function looks like, or what the liver enzymes look like. So I want to point them out to you all today. So electrolytes are going to be, if you look at the slide, the sodium, potassium chloride, carbon dioxide. The anti-gap is a calculated value, which you should only have to worry about, okay? But these things also help me as a physician know whether or not, say, for example, your blood pressure is high because of a adrenal gland problem, okay? Or some type of, sometimes you can see potassium levels go up in renal disease that's severe, okay? The test that you want to pay attention to, and there's a piece that's missing from here, but I'll share it with you verbally. So we look at the BUN, the creatinine, and something called the estimated glomerular filtration rate. So the word estimate is not on here because I don't have a calculation in there, and that is exactly what it is, an estimated value of what your kidneys are doing. But it is one of the most accurate tests that we have available to us on a simple blood test to say you're developing chronic kidney disease or you're in acute kidney failure, right? Or acute kidney injury. So the creatinine is what we look at first, and most people are familiar with that test. And if you're above a certain level, we go, ooh, let's take a look at that, right? This is where we get into the process of evaluating you. And if the estimated glomerular filtration rate goes below 60, that's a problem. So 60 to 90 is normal. Greater than 90 is great.
Hey,
Okay.
Dr. Spears,
Yes.
my apologies for cutting you off. I just wanted to recognize our Brother Malwan Johnson for coming into the room, our International Director of Social Action.
How you doing, Brother Johnson?
I'm good. I'm good.
All right. All right. So those, can I just go back? So those are the 3 tests on here that we look at for kidney function, okay? And I mentioned the liver enzymes, liver function is also here. So your AST, ALT, the total bilirubin, and the alkaline phosphatase levels are associated with gallbladder and liver function, okay? But we're not talking about that today, but I want you to be aware of that. And there's some other tests that we use to really truly assess liver function. And maybe one day we'll talk about diseases of the liver so you can understand that too. But moving down, the next step in the evaluation is usually we do this staging of chronic renal disease, right? So stage 1 basically is normal. And stage 2 is you're somewhere between that number 60 to 89, Brother Nichols. So this is where your loved one is at, okay? We talked about that briefly the other night. And so that's okay, okay? As long as he's not on the low end, he's going to be okay. And it just needs to be followed. Stage 3 is divided into A and B because what we look at with some people with diabetes is whether or not they're spilling protein in their urine. So you've heard me do talks on diabetes management and monitoring. And one of those tests that we do to monitor diabetes is something called the urine for microalbumin. Okay, that's a protein. And when that number gets above a certain level, we get more concerned that there is microscopic injury to the kidney, even though the BUN and creatinine and the eGFR are relatively normal, okay? So we want to keep that in mind. So spilling a large amount of protein in your urine is a sign of injury to the kidney. And that can happen with high blood pressure, certainly can happen with diabetes that's not controlled, okay? And we get all the way down to stage 5, and that means you're on dialysis. That means you're not making urine and things of that nature, okay? So when we get to this point, for example, when someone's at stage 2 renal disease, now let me go back one time. So I want to make sure I get this in there. Normally below the value that it tells us about the glomerular filtration rate, if it's less than 60, the lab will write in there that the patient has stage XYZ renal failure, okay? And that's a scary term for most people to say, "Ooh, I've got renal failure," but I want you to make sure that you remember this slide when it comes to that, right? Because it'll be in there like that. It doesn't mean that your kidneys have failed, but they're having an issue. And that's all there is, okay? So from this point on, there are some other things that when you get to stage 2, 3A, 3B, et cetera, or that's how you show up to the doctor's office, there are other tests that can be done, okay? And we're going to go over those evaluations so you know what they are. So I just mentioned these tests, urine albumin, and this other stuff is calculated values, this urine albumin creatinine ratio, which is important in how we monitor diabetics, okay? Urine sediment is just a simple urinalysis. So there's something we can do when we're looking at someone with chronic renal failure, but it's better if there's an acute renal failure because we're looking for certain elements within the urinalysis, and they're called red blood cell counts or white blood cell counts, and it helps tell us whether or not this is a failure from, say, a breakdown of your red blood cells, that's called hemolysis, or whether this is an infectious component and you have some type of interstitial kidney disease, okay? And there's some other elements that go into it. So one of the first steps in evaluating kidney function is you got to see your primary care physician, right, annually when you reach a certain age. And so you have that chemistry profile that we talked about, and that'll tell us whether there's an issue. Some of the other tests that we would do at a routine evaluation is a blood count, your chemistry profile, let's say, and the urinalysis. Now, if you turn around and have stage 2 or stage 3A renal disease with no known cause, say you're not diabetic, you don't have high blood pressure, you're not taking any medications, right? Then we got to start looking deeper into why you have it, right? And we have to monitor you a little bit sooner. So the next step is a renal ultrasound, right? We take an ultrasound picture of your kidneys and measure the size of it. And sometimes if there are other elements that we might do, if there is uncontrolled high blood pressure or what we call resistant hypertension, we might do an ultrasound or a renal duplex study of the kidney arteries to see if that's a reason why all of this is going on, because that can make you go into renal failure real quick, particularly if you're taking certain medications for your to manage your blood pressure. So those are some of the simple things that we have at our disposal to start looking for elements of chronic kidney disease. Let me get one more slide. So as part of that management process, your doctor will at some point say, you know what, I don't like these numbers. I want to send you to a nephrologist. And the nephrologist is going to repeat all those tests that we just talked about and may do more. And the next, I guess if your stage is 3B or 4, then we don't have a cause per se, then that's going to cost you to have a biopsy of your kidneys to look for underlying reasons. We usually will do that just to kind of go backwards a little bit in children, right? When there's acute kidney failure or we see elements of chronic renal failure, we don't know why, they'll biopsy the kidney to look for what's called glomerular diseases, okay? And we do that in adults also sometimes when we can't figure it out. So for example, I have a patient currently in the hospital who I knew had chronic kidney disease, but she was very stable. She's diabetic, uncontrolled, right? And her estimated glomerular filtration rate was 60, okay? But she was making urine, she was doing everything. And all of a sudden she comes into the hospital after a fall. She cracks her face, and then we look at her kidney function, and her creatinine was 16. So we see that in complete renal failure. So, but based on the story that she told, we know that she had what's called intravascular depletion, meaning that along with, she was taking a medication. One was a diuretic, right? And the other was a combination pill for her blood pressure. And she had a bout of severe diarrhea. So she was pushing fluid out and not putting anything in, but still taking her medication. So she went into acute renal failure. So our hope now is that she doesn't stay or worsen her chronic renal failure by this act, okay? So we're holding her medications for her blood pressure and stuff like that. So that's part of the management. So there are some clues to when do we refer to the nephrologist. And I got 3 of the major ones here listed.
Can I ask a quick question, Dr. Spears?
Yes.
So before I would get to this stage, what would be some symptoms that I may have something going on with my kidneys, even before we get to this stage?
Okay, you might not notice anything, right? Stage 2, you're not sick, you don't have nausea, your feet are not swelling, things of that nature. You're not getting short of breath because you're retaining fluid. You know, and we look at when people start having trouble breathing, we have to look at certain organs, right? We look at the lungs, we look at the heart, and then we don't see anything there, we look down at the kidneys, but that's still going to be seen on routine blood tests. Okay, so really, this is a very silent thing. You could have elevations in your blood pressure not responding to medications, and that's what we call resistant hypertension. So those are some of the things that we look at. So if you got somebody, or I have someone that is on 3 or 4 medications and they're not getting controlled, I have to wonder why. And this is when you go start looking at the kidneys and the adrenal glands. Okay, looking for a hormonal reason for also, and that's what the adrenals do, for a cause for their high blood pressure, which can affect the kidneys over time. Did that answer your question?
Yes, sir. Thank you.
All right. So in the first one here, urine albumin to creatinine ratio, I mentioned that earlier. So when you get up to 30, now this says graded, this is referral to a nephrologist. So when you get over 30, I as a physician get concerned, because that tells me that you're not controlling your diabetes, you're not controlling your blood pressure. But when you get to 300, you're in trouble. Okay, so you need that nephrologist to do a further investigation and tell you what you should be doing as far as diet. When it comes to eating certain foods, you can make some matters worse if you say on a very high protein diet, things of that nature. The next one is inability to identify a cause for your EGFR declining in more than 30% in less than 4 months. So we're seeing you do this here, that's a problem. So go see the nephrologist, they're gonna run a whole bunch of battery of tests. Some of what you've already had, but they like to repeat things. Now, one of the other elements that we see in people who have chronic kidney disease is they become anemic, and then they may have elevations in their changes in their calcium level, which would suggest a possible hyperparathyroid. That's a small gland that's embedded in the thyroid gland. But usually when you get to renal failure, that's called pseudo hyperparathyroidism. So you'll see elevations in the calcium levels, and that can cause other issues with your bones. Okay. Now, there's some other elements in that also that we look at. If there's blood in your urine, we also want to look at the medications. And again, if not able to identify the source. And so we want the kidney doctor to start looking at things, because for example, if you're anemic, there are medications that we can give to correct that, but you don't want to just assume it's due to kidney disease, right? So if you're going to the doctor on a regular basis and we see for example, you have stage 2 chronic kidney disease, you shouldn't be anemic from that. So we have to look at other sources of why, right? You're anemic. So we start with the process of looking at your iron levels, your B12, folate levels, and things of that nature. If you've had a colonoscopy in a given amount of time, or recent or not. And we also do what's called an EGD to make sure we look for all sources of lost hemoglobin. Another source of becoming anemic that can have an effect on the kidneys is there are conditions called plasma cell disorders. You all may have heard of multiple myeloma, Waldenström's myeloma, or monoclonal gammopathy of unknown significance. You don't ever have to remember those things. That's just something that I know. And all of those diseases are caused by abnormal proteins, and they can damage the kidneys. Amyloidosis is another one, and you probably have heard about the commercial about the heart. Was it transurethrin, something like that? I can't remember the name of it, but that's basically amyloidosis. So it can affect the heart and it can affect the kidneys also. So we also refer to the nephrologist when we start seeing electrolyte abnormalities, such as potassium levels that go above 5.5, phosphorus levels that go up high. That's time to see the nephrologist without question. Okay. So if they're not there, that means there's time, and there's things that are correctable. So if you got diabetes, you have high blood pressure, getting those things under control and keeping them under control should never have an issue with your kidneys. Okay. And I think I am done with that. So I'm going to turn it over to Brother Jenkins and let him talk about some of the common causes of medications that can cause some issues with your kidneys. Now, this is not to say that we're telling you not to take these medications, right? But to be aware of the potential side effects. Brother Jenkins. So let me stop.
Thank you, brothers. Thank you. Thank you. Good evening. My name is Antoine Jenkins. Yeah, stop sharing. That would be great.
Let me stop sharing. Hold
My
on,
name
I'm in
is
the wrong
Antoine
thing.
Jenkins.
Hold on. Go ahead, talk. I'm trying to figure
I'm
out
a
this thing out.
pharmacist by trade, and as was mentioned, I'm going to talk about some of the more common.
Okay.
Breaking
Did I
up.
stop sharing?
Well, you said hold on, so I got confused.
Oh, I'm sorry. Did I stop sharing?
No, we can still see your screen.
To talk
Well,
about
okay, hold on. Let me
some of
figure
the
this out.
more common
And
What?
brother, Dr. Jenkins, his audio is not coming in clear.
that could have an impact on
Here we go.
I sent him a text.
Okay, hold on. Let me get out of
you
here.
still see your screen.
I'm trying to find the thing that says stop sharing.
Dr. Jenkins, your audio is terrible. I'm not sure if you're in a bad area.
Really?
Yes, sir.
All right, somebody tell me where the thing that says stop
Can you all hear
sharing.
me?
I can hear you now. Yeah, and I can't. Let's see if I can make it stop sharing your screen.
All right, because
Nope,
I don't
can't
see it
make
on mine. You sure it's not?
It'll be at the bottom. It'll be the green up arrow at the bottom.
Yeah, I got that, but
You
I don't
just-
see where it says stop sharing.
Just click the arrow. It'll stop it automatically.
Click the arrow. Okay, then I think I did that.
Or there should be something little red. You got 2 monitors?
No,
Chance.
I still don't see it.
I don't know if Dr. Jenkins has a PowerPoint. But
Here,
if
I can stop your sharing for you. There you go.
Okay,
Okay,
perfect.
good. All right, sorry guys.
You there, Dr. Jenkins?
I'm here. Can you all hear me?
You are breaking up, but we can hear you.
Hello? Oh boy. I don't know.
I can hear you. Can you hear me? Well, let's Dr. Brinson, are you prepared to move forward until he
I am. Let's go ahead and give him let's give him a while to get things situated. It's not a problem. We're going to jump right on in to my presentation. Let me share this screen. All right, and let me now get this PowerPoint going. So good evening, brothers. I am going to talk about the psychological effects of being diagnosed with kidney disease this evening. So what I have in store, we've already heard from Dr. Spears about all of the, many facets from a medical standpoint as to what happens when a person gets diagnosed with some type of kidney ailment or disease. So I'll talk about the psychological piece of that, because while they are getting diagnosed with that, something is stirring up psychologically. So we'll get into that this evening. So my agenda, I'll introduce myself. I'll talk a little bit about what I've done and my expertise I bring to this particular arena. We're gonna delve into receiving a diagnosis of kidney disease, some of the mental health challenges that comes along with that, and dive just a little bit into the emotional toll it'll take on the person, because the whole entire goal is to manage and cope with that ailment. Because we get good management and good coping skills going, then that person can do all they can to try to mitigate what's going on with them. So I am a licensed clinical psychologist who is PsyPAC approved. So let me just tell you guys what that is. I'm licensed here in the state of Illinois, but because I am a PsyPAC approved psychologist, I can provide services across state lines. So that means if a person is in any of the PsyPAC approved states, I can provide psychological services to that person virtually. I am a co-owner with my wife, who is a soror of Dr. Tyree Brinson and Associates / Life Management Solutions. We are a mental health company, and we also provide not only mental health services, of course, but also clinical and also consultation services. In addition to that, I'm a clinical director of an adolescent treatment program in the city of Chicago. In addition to that, I'm a psychiatric services manager with a contract that we have with the Department of Children and Family Services. So if there are children in custody who needs any type of psychiatric medication, they will send that information to me and I will approve it or deny it based on symptomatology and other other things that we utilize to be able to determine that. I have privileges at Advocate South Suburban Hospital, and that is the piece that lends some of my expertise to this subject this evening, because I work with surgeons who are operating on people who are morbidly obese. And Dr. Spears knows this, that when that obesity level rises in a person, so does all types of health ailments, and one of those can be kidney disease. So I work alongside of them to be able to manage their life psychologically while they're going through this transition of trying to manage that weight so they can alleviate a lot of those health ailments. And of course, I'm a member of Phi Beta Sigma, a life member. In fact, I was initiated in Beta Theta back in '92, and my current graduate chapter is Omicron Alpha Sigma in the South Suburban Chicagoland area.
Beta Theta.
Absolutely, absolutely. So let's talk about receiving a diagnosis of kidney disease. And I always tell patients when they call our office, the therapeutic process starts when they pick up that phone. Immediately once they pick up that phone, it starts the process of them learning about themselves, making a commitment. I look at the same thing being true when a person is receiving a diagnosis of a chronic kidney disease. When that doc provide that medical testing and tell the person come back next week and I'll tell you those results, immediately at that moment, that person starts to go through a process. And that process is how they are going to receive that diagnosis, that serious diagnosis, which in a lot of cases, like we looked at with Dr. Spears, they got like from stage 1 to stage 5. So all of those things runs through a person's mind when they know they are about to get some test results. In this case is whether or not they have a kidney disease. So we do know that minorities have a higher rate of comorbidities that increases the risk of kidney disease. What does that mean? I talked about obesity. We know diabetes is one of those factors. So there are a gamut of things that minorities just, unfortunately have a higher rate of ailments that can lead to a risk of kidney disease. Now, the value of that relationship, so imagine that person waited a week to get those metabolic tests back, those test results back. So it's very important psychologically, because the value of the physician and patient relationship will be able to set the tone for them receiving that information. What do I mean by that? If they don't trust that doctor, then they may not trust those results. And that, and we know if someone questions, of course, we know that they can have a second opinion and all of that, but if they question whether or not they even have the disease, even if they have the actual proof, then that's a problem. So, so that relationship with that physician and patient is really a integral part of that person receiving that information. And therefore, if that person can receive it, it might be able to help that person do what he or she have to do in order to get better. So how does that person prepare for that potential of that diagnosis? We all know in this day and age, well, back in my day, we used to have, what is that, Encyclopedia of Britannica. But now we have Google. So I guarantee you most patients, right before they're to get whatever diagnosis or whatever test results, they go to Google. And when they go to Google, Google doesn't tell them whether or not whatever they're looking at applies to what's going on with them. So, so without that interpretation, their mind starts to run and they start to build up. And anytime you're thinking about getting any type of results, the first thing you may think about is sort of the negative part of that. So they start imagining, well, what if I have this, and then how will I survive, and what changes will occur? So the period between the test and the results is significant in that person preparing to be able to do what they can psychologically to be able to manage whatever is afflicting them. A personal reflection, oftentimes enter into that equation. So they start reflecting, well, I shouldn't have, been obese most of my life. Maybe I wouldn't have, had this kidney disease. Or maybe, if I would have been able to exercise like the doc told me. So a lot of personal reflection, goes on. And I'm sharing this with you guys because it's building up what may be going on psychologically. So I want you guys to think about this as swirling around. They're trying to make sense of what's going on, and it's, manifesting in some type of way psychologically. So what we look at in terms of psychology is whether or not that person's environment is supportive or non-supportive. And we're contemplating that because if they are in a supportive environment, you already know that they may have some, external resources that can be able to help them to receive the diagnosis. But if they're in a non-supportive environment, can you imagine that all they have is their cell phone and Google, and then that next appointment? So all of these factors we think about from a psychological standpoint, because that person at some point will walk through our doors as well, and we want to, be able to understand and conceptualize what might have led them to that point. Resources may affect that perceived outcome. So if the person know that they don't have money, and I'm pretty sure that the docs on the line can attest to someone saying, well, doc, how much will this cost? How much will all this treatment cost? I can't afford to have kidney disease. I don't have, money to, for dialysis. How will I pay for this? So we know that resources can definitely affect that perceived outcome. And even with this, if they know they don't have, and I can see this all the time when people come in and say, well, I have this chronic, ailment, but I'm trying holistic measures. Or I'm trying to research and I'm trying to, figure out another way to deal with this. Oftentimes, on the outside, it looks like they're just going a holistic route. But then if you peel that apart, you realize that the person did not have the resources to sustain, from their perspective, adequate care and adequate coverage. So to sum this up, there is no one reaction. It all depends on the individual's outlook to be able to receive that information. If they're positive, then that they can receive that, sort of in a positive way, in an optimistic way. But if they know that the odds are stacked against them from the start, then that will definitely lead to either, Dr. Spears having that appointment, with them, knowing that it's Thursday at 7 o'clock and they miss it. Well, guess what? They don't just miss it, just to say I'm just blowing this off, but it's the manifestation of what's been going on psychologically that's powering them not to be able to face what's going on. So let's talk a little bit about some of those mental health challenges. We've talked about that person receiving a diagnosis. Let's say they receive that diagnosis and they're now starting to deal with that diagnosis. Well, they don't just start living from that point of that diagnosis. We as psychologists look at what are they coming with. Does the person have any pre-existing medical problems? Because guess what? Those medical problems won't drop off. Those mental health problems or those medical problems won't just drop off because they got a diagnosis. So in other words, this diagnosis that they have don't supersede any other psychological problems that they might have been experiencing up until this point. We look at the person's past and recent history to be able to lend us some information as to the makeup of the person and how, what type of resource that person might have. We look at their personal life. Have they, got this diagnosis? And then we also know that they, just had a divorce 2 years ago. And the timing is never right when you get, any type of serious diagnosis. But could you imagine a person's personal life not being in order, to be able to support or even accept that they have a serious medical disorder? We look at that person's baseline, their psychological disposition, to be able to help us to be able to understand and get that person to start to move in a positive direction. And we also see those protective factors that are available to that person that we can probably tap in and utilize. Because if the person, if they receive that diagnosis not favorably, then I guarantee you that they won't follow the doctor's orders. We know these things, so that's why we, scan a person to be able to find out some useful information that may be able to assist them. Because we know that there will be some emergent risk factors just by the nature of them getting this serious diagnosis of kidney disease. We know that the literature shows that, there can be an increase in substance usage. And this is because, they obviously they don't have the coping resource to be able to, to manage and even deal with it. So substance abuse goes up, usage goes up because they're self-medicated. They want to forget. They want to just, go off into another place and not really address it. We know that depending on, that disposition of that person, let's say they already came with, depression, history of suicide. Well, guess what? We have to, now that they have this serious medical condition, we have to definitely screen for suicide. Now, I don't want you guys to think suicide like going to jump off a bridge, but suicide comes in many different forms. It can be slow and insidious, whereby the person say, I'm refusing all treatment. I'm not going to dialysis anymore. I'm tired. In essence, they've given up. So that, is their way of saying, I want this over. We know another emerging risk factor can be withdrawal from treatment, like I just mentioned, extreme non-compliance, where every time they go in to see, the pharmacist, every time they go in to see the doc, they just don't follow through. I could imagine a psychiatrist saying, hey, you have to take a certain amount of medication. They got to, be able to level things out. But to know that the person is not, taking it once a week versus every day. So we have seen a lot of instances of extreme non-compliance with treatment. Also, another emerging risk factor is their attitude toward treatment. If they come in thinking that they won't get better, then I guarantee you they won't get better. So we are in the psychological realm, work with them to be able to shift around and change that attitude and try to boost them up to gain some positive momentum so that attitude can start changing. Even if they've not been, predisposed to, depression before they got that diagnosis, we know that once they get that diagnosis, even if they've not had a history of depression or anxiety, we know that those levels spike. Now, whether or not they'll get to that clinical range, we have to look at it, but we know that, it's going to spike. The research shows that it spikes just because, of that jolt of having this extreme change in their life. We know that fear is a part of that, fear on what's to come, how in the world, can I deal with this? I don't want to lose my toes to all the diabetes, and I don't, how that fear comes out, and a person have to, figure out and learn how to manage that fear. Also, an emerging risk factor is the treatment itself, as well as the length of the disease. I could imagine someone coming in and saying, Doc, what do you mean I have a chronic kidney disease, how long will I have that? How long is this? Is there any end? Is this a 6-month thing or is this a lifelong thing? Those kind of the length of it definitely matters because it essentially alters how that person is going to live the rest of their years. All right, so let's now look at the emotional toll it's going to have on a person. Like I said earlier, there will be a change in a person's mood. We just have to figure out whether or not it's on a clinical level or is it going to, naturally go down once they, get going and get, and build some confidence on dealing with it. It can definitely chronic kidney disease. The literature shows that it's depression. Well, when a person has chronic kidney disease, there's an increased risk of depression that we know that can rear itself in that person's course of that disease. We know that lifestyle changes will occur and that'll have an emotional toll on a person. So we know that they have to change their diet in a lot of ways, and that's one of the hardest things to do. We know socially, if they don't have that support, that's a change. We know that maybe they got some occupational issues. Maybe they don't have time off from work. We know that it's gonna definitely start to change things, and all of those take an emotional toll on that person. Financially, sleep is being disturbed, and with depression, comes concentration problems. So we're going to see all of these things to be able to manifest and start to take a toll on a person. And if we start to see the person start changing their goals and unplugging from things, that can be an alarming situation for that person. So now let's move into managing and coping. So a level of acceptance is important. So when a person get those test results, go to Dr. Spears, find out what's going on, and say, okay, doc, I understand. So I gotta make some changes. Tell me what I need to do. That's a good prognosis for a person who's going to accept that they have this ailment. It's not necessarily a good prognosis for the disease course. That is dependent on how well they follow that treatment plan, but that level of acceptance is quite important. They got to be willing to communicate and actively engage in their treatment planning, and to communicate some of those feelings, with that support system. It's important for them to connect with the specialist and a physician team in order to build trust. And the people on that physician team include the psychologist. It sometimes includes the dietitian, the internist, the nephrologist, even a physical therapist. So connecting with those specialists are important to get that person, activated in terms of trying to get better. One of the most important things, they got to be willing to accept help when needed. They got to ask for help and they have to be able to accept it when needed. Psychologists work to be able to address some of those feelings, anxiety, depression, stress, of course, and secondary to that medical treatment team. We are an adjunct to it in terms of psychology, so we work to build a psychological treatment plan as well. So that will include family members. So we'll work with the family members to make sure they provide that home support that's necessary. Maybe making sure that person makes those appointments, and just take the medication and follow that entire regimen. We try to get them to practice self-care. A lot of times when a person gets any type of chronic disease diagnosis, they pull away from those things that they like. Bike riding, typical things that they like. So we try to get them to re-engage those things because it'll, start to boost the mood and also create a better outlook. Again, we connect them to that social support groups, the social network, because they are just as important as the physicians and the psychologists, because they're gonna, push that person to keep going and keep encouraging that person. So in other words, we try to develop a positive outlook, and also, try to get them to buy into a good trajectory for the course of this illness. So in conclusion, the relationship with the physician is vital throughout this process, of course. It's important for them to gain awareness about their feelings and how in the mood shifts. We tell them, hey, you might expect, to not feel as good Part of that is, that normal way you're supposed to feel, but if it is prolonged, then it's definitely time to get some assistance. Communication is important, talking about those feelings, connecting with that treatment team, addressing those concerns as they come up and manifest. Self-care is important, and also continue to have a positive outlook and work toward those goals. So some final tips and takeaways. Again, the key term here is communication is vital. Build that support system, connect to a psychologist to manage the chronic illness and disease from a psychological standpoint, and address those mental health concerns as they come up. So brothers, thank you. This is my contact information. I'll take questions if you guys have them.
Thank you, Brother Brinson. Brother Dr. Jenkins.
I am here. Can you guys hear me?
Yes.
Hello?
Yeah, I can hear you.
That didn't sound like a convincing yes.
It's better right now. Don't move from wherever you at.
Okay. I'm sorry, fellas. I have no idea what's going on. Zoom was working just fine yesterday and earlier, so I
No,
don't know.
you're good right now. Just wherever you
and for
sit,
whatever,
sit right there.
okay. Okay. I will. And for whatever reason, my camera's acting funky. I have no idea. Maybe it's tired. I don't know. But I will go ahead and share my screen. And I don't have a lot, just FYI. Can everyone see my screen okay?
Yes.
Yes, sir.
Okay. Okay. It's weird because I can't even see my screen. It's very weird. I don't know what's going on, but I'll get through it. I don't have a lot. So I am Antoine Jenkins. I am a pharmacist by trade. I am the second vice president of Epsilon Zeta Sigma based out of Gary, Indiana. And I'm the newly appointed state director for the state of Indiana. So it's indeed a pleasure to speak with you gentlemen today on a topic that's kind of near and dear to me. Anything pharmacy related happens to be near and dear to me. So I'm going to talk about specific drugs that can cause kidney impairments. And when we think about the kidneys are a big deal organ, right? So they do more than just make you pee. It's really above, they go above and beyond that. The kidneys play a role in terms of regulating electrolytes. The kidneys play a role in terms of making red blood cells, right? And kidneys play a major role as it relates to regulating blood pressure. You probably think that would happen more so in the heart. No, the kidneys are more so the predominant player there. So kidneys are a big deal. So because the kidneys are a big deal, there are some drugs that can, let me put this in presentation mode. There are some drugs that can be a common cause as it relates to what's called acute kidney injury, right? So let me just state this disclaimer whenever I talk about drugs, right? So just because a drug has a listed side effect does not mean that you individually are going to develop that side effect, right? So side effect profiles are developed from a population of individuals within studies. And like I mentioned, just because it's listed does not mean that you are going to get it. But it's important to know, especially if you already have a diagnosis of chronic kidney disease, it's important to know what specific drugs can potentially make matters worse for you. Now, there are certain factors that would make one more susceptible to experiencing what's called acute kidney injury. Individuals of older age, specifically individuals over the age of 65. So when we get older, we are more susceptible for a lot. So acute kidney injury is definitely one of them. Body mass, and that specifically as relates to how much muscle are you holding. So individuals with reduced body mass, individuals who are more frail, they tend to have a greater chance of developing acute kidney issues. Females in comparison to males, and that makes sense because females typically carry less muscle. those previously diagnosed with chronic kidney disease, individuals who are dehydrated, and Dr. Spears kind of touched on that a little bit. And then individuals who have had prior exposure to drugs that can impair kidney function. All those things can play a role in causing a patient's kidneys to fail in a sense. And there are different types of chronic kidney injuries that can occur, right? So for example, there are some drugs that can reduce blood flow to the kidneys. So that in and of itself sounds bad. So that can cause a type of acute kidney injury. There are drugs that are directly toxic to the kidneys, which can actually cause damage to the kidney tissue itself. So there are drugs that can do that. And there are drugs that can actually promote the development of kidney stones. So that's something that we've all heard of. So there are certain drugs that can do that. Now, this can actually be a 2-hour discussion, but we're not going to do that in 2 hours. I do want to talk about some of the more common drugs that can potentially play a role depending on the patient. So blood pressure medications, these are very common, right? So I have the drug class name listed here, the example drugs within that class, and then what to do if you're taking one, right? So some
Dr.
common drugs.
Jenkins, could you flip the slide?
Back here.
It's still on your introduction.
I don't know what's going on. I apologize. I am moving the slides. I'm advancing them, but y'all can't see.
No, no.
Okay.
You
But
want
we
me
can
to-
hear you, and that's good.
Yeah, go ahead. Go ahead and stop sharing. I'll get your presentation on the screen.
Okay. What about now? I'm not in presentation mode. Can you see the slides now?
Yes, sir. You're good.
Okay. So you guys see a table where I'm talking about blood pressure medications, right?
Yes.
Okay, so maybe I'll just stay here. And as you can see, I only got 5 slides. So blood pressure medications, very common medications. Most individuals are taking them because hypertension is definitely rampant within our communities. So there are a wide variety of different blood pressure medications, but these are definitely some common ones. So medications that end in PRIL or pril, such as lisinopril, enalapril, this drug class have been associated with chronic kidney impairment. Drugs that ends in TAN, such as valsartan, losartan, and water pills. And there are different types of water pills. Hydrochlorothiazide or HCTZ is one, or furosemide or Lasix, very common one as well. These could potentially, like I said, they've been associated with causing acute kidney injury. So what do you do if you're taking one of these? Well, if you already have CKD, if you already have the diagnosis of chronic kidney disease, talk to your physician to make sure that the dose is actually correct. Because what part of my role as a pharmacist, when I'm assessing the medication's profile, I'm going to make sure that the drug, not only is it appropriate, but also it needs to be dosed appropriately per that individual's renal function. So if the dose is too high, depending on how well the kidneys are working or not working, I'm going to make that recommendation for a dose change. You never want to stop a medication on your own. And like what's been mentioned previously, we live in an age of quick technology, and folks are Googling stuff all the time and looking up stuff all the time, as they should. You do want to do your research on what your physician's telling you, what your pharmacist is telling you, but you want to make sure that you're getting accurate information and talking to individuals that you trust. So before you stop any medication, make sure you have that dialogue with your provider so that you all can be on the same page. The next common class would be what are called NSAIDs, or non-steroidal anti-inflammatory drugs. So these are drugs that are pain relievers. There are multiple examples that are prescribed. There are some that are available over the counter. So I definitely want to make sure I talk about those. So examples that are over the counter include Aleve and ibuprofen. So the thing about these drugs being over the counter, of course, you don't need a physician's say or prescription to get it. You can get these drugs whenever you want to. So what do you do if you're taking one of these drugs? Well, if you don't have CKD, if you don't have a diagnosis of chronic disease, always use the dose prescribed, or always use the prescribed if you have one that's via prescription, or the bottle if it's OTC, or the shortest time period is possible. Drugs are great in relieving, most types of pain. Like whenever I have a headache, I typically use Aleve. For me, Aleve works better than ibuprofen. Maybe that's just in my head, but it does. But I want to make sure that I'm using these drugs for the shortest duration as possible, because even though they're over the counter, just because the drug is over the counter doesn't mean it's going to be completely safe, right? So you definitely want to make sure that you're using the drug only when needed. Now, if you do have CKD, this definitely does warrant a discussion with the provider, especially if you're using one of these drugs to treat some chronic pain that you're dealing with. There needs to be shared decision making that takes place. You want to make sure that you are getting just the right amount of drug that you need for treating whatever chronic pain you're dealing with, but not enough to cause any potential adverse effects such as kidney impairment. So definitely make sure you have that discussion. There may be alternatives other than NSAIDs that you can use to alleviate that chronic pain, but always have that discussion with your provider. And then my last slide, always talk to your pharmacist or provider to determine if a drug is right for you. Even over-the-counter medications and even herbal medications that you can go into GNC or Vitamin Shop to pick up, those, just because they're readily available doesn't mean they're going to be completely safe. So I always ask the questions in terms of, will they in fact be right for you? And do they potentially have the capacity to elicit? So that is all I have. And hopefully you guys heard that. I hope. I don't know what's going on.
We heard you.
Okay, cool.
Thank you, Dr. Jenkins. Any questions for Dr. Jenkins? Any questions for any of the presenters? Dr. Spears,
Well,
you like to-
Well, I don't have a question, but I have I guess you say a comment. In the last 2 weeks, Doc Spears and I are in the same chapters, so he's aware. But in the last 2 weeks, I don't have a chronic kidney disease, but I have a problem with my kidney. And in the last 2 weeks, I found out that I have a mass on one of my kidneys. And I'm scheduled now to have one of my kidneys removed. So what I want to know, going back to what Dr. Tyree was saying, when I first got the diagnosis, I have a Living Well app. So I knew what the results were 2 hours after they did the test. And I started doing my research. And there were a couple of words on there that I knew was reference to cancer. So I had an idea. So mentally, all this stuff was going through my head where I got cancer. But I'm old, so it didn't bother me as much. And then I started thinking, and then I just put things in perspective, is that I can live with one kidney. And it hasn't spread to any other part of my body right now, so I can go forward. Now, there's still some things that bother me mentally, but I'm dealing with it in a positive way. Okay, I really am. And I know that I have a good support group around me. I got my frat brothers, and I got my family first, and then I got my frat brothers, not Doc.
That's messed up. That's messed up.
But
Wow.
what I'm trying to say is that I had no idea that I had a kidney problem. And I woke up one night with excruciating pain on my right lower side. And it was so much pain that I had to go to the emergency room. And I stayed in the emergency room for 5 hours. And the doctor there told me I was passing stones. So I'm waiting on my stones to pass, and nothing happened. But he had put IV in my arm for pain, and the pain went away. So he misdiagnosed me, but he gave me a disc to give to my urologist, and I went to the neurologist the same day. And I'm trying to make it short, but it's a long process. But it's taken me 2 weeks to find out. Wait a minute, let me make sure. Yeah, I found out on July the 3rd what was wrong with me. Okay. And what caused my pain and all that. And all of you guys know, and you can look at how many brothers on this call now. Black men need to start talking to each other and try to find out things about their health instead of ignoring stuff. Because we got 7 brothers on here. That's ridiculous. We need to be on this call trying to find out about our health. Now, I'm gonna put a pat on Doc's back after I locked him down. We are having a prostate, well, we're gonna call it men's health wellness, but we having a prostate seminar, and I've got my urologist and I've got Doc's gonna be there to get black men. It's gonna be at my church to get black men to come out. Now, if they don't show up, I'm gonna get up in the church. I'm gonna be mad because black men do not come together to talk about things. And from the knowledge we've got here tonight, there's nobody going through something that no one else hasn't went through before. You just got to have somebody to talk to. And Brother Tyree and I are from the same undergrad chapter. And I know right now that I can call him if I get down that bad, and he gonna help me. If I need something,
right, brother. All you gotta do is call.
I know. I can call Doc and get an answer to things. But I'm saying that we need to get make a stronger effort of, I sometimes say you have to yell at people. Black men need to find out about things in their body, because your body tells you things that you need to know. And if you don't listen to your body, you're going to be in trouble. I mean, I'm old. I'm 73, and I got to this point, and now things have started falling apart. But mentally, it's not affecting me as of right now. Now, I don't know what's going to happen after the surgery, but right now, it's not affecting me. I'm still going on with my life. And no questions, but that's my comment. Thank you.
That's
Thank you,
good,
brother.
bro. And just so you know, I've talked to Brother Nichols about the development of and we talked about this, of a survivors network, people who've had various illnesses, so that that conversation that you're talking about can occur for people who've had that experience, say, for example, colon cancer, heart disease, things of that nature, prostate cancer, so that brothers can go and talk to someone who's had that experience and get some insight, right? So that's something happening again. As always, you can always count on me, right?
Can I just say, Brother Williams, I absolutely appreciate your comment, and you're spot on. Black men need to make sure that we're taking charge of our health. Unfortunately, just due to the history in this country, with Black people in general in the medical community has not been the greatest, as we all know. And even in contemporary times today, unfortunately, there's still a lot of what's called health disparities that take place, a lot of misconceptions about what physicians think about Black people. For instance, there are some physicians who think that Black people have a higher pain tolerance as to
You break it up a little bit, bro.
because they think we have a higher pain tolerance, pain medications that a white person would. Fortunate, but we're trying our best to spread the word within our region, and it's definitely a slow process, but um, it's like we're trying to combat things that's taking place in history, and honestly still trying to combat things that are still going on today, unfortunately. But you have good brothers like the great Dr. Spears leading folks in the right direction. So that's all I had to say.
Don't
Anybody
call it
else?
great.
See, you know what? You know what? I'm gonna get you. I'm gonna get you. First chance I get. Trying to
All
be
in love.
professional.
All in love.
Uh-huh. All right. So if there's no other questions, I appreciate everyone that is on the call, the presenters, and my chapter showing up, for this. It would have been really great if, like you said, Marvin, we've been doing this right now, right, for over a year, these type of calls. And so this is about average, right? We've had a couple that we've got in the 30s, no, 40s, I think, but that was also in conjunction with our sisters. So we're still working on that. I mean, I think people have to understand that, they can't continue to live in a bubble and that they need this information and not wait until something happens to them or someone that they care about to be able to start asking questions. And until people understand that, then we're going to continue to, not do well when it comes to our health. And so, I'm doing my best. I know the brothers on this call that did put presentations, doing their best. And so we got some other brothers that are in the committee that couldn't make it tonight. But, we're doing our best. We're seeing more participation from some of the brothers in the healthcare profession on our committees, on both international and regional levels. And I think that, with our leadership being the way it is, we'll get there for the region and hopefully drag the international side along the way. Okay, so if no one else has any questions regarding the presentations, I think that you're going to be able to be a little bit more well informed about your health and when it comes to kidney disease, and we'll go from there. And Brother Marvin, once you have your surgery and you have one good kidney left, you'll see, I want you to pay attention to your creatinine levels because they're going to go up a little bit, okay? And so you have to be mindful of the medications that you're going to be given, the over-the-counter medication that you might want to take, like was mentioned by Brother Jenkins, you could take ibuprofen, right? But you can't take it every day. You can't take it in prescription strength every day because you hurt that kidney that's left. And so you'll need to have good follow-up on that. And be careful about the other stuff that you're given by your doctor, right? Sometimes we'll react and we don't think that, about the consequences of the medications, and so you need to be aware. So as long as, me, or I'm alive, you can always ask me questions in that regard, okay? And I promise I won't send you a bill.
It's recorded, so you can always refer back.
Thank you.
Well, I shouldn't have said that, huh?
Uh-huh.
All right. Well, let's if it's okay with you, Brother Nichols, let's call it a night.
Well, actually, he had to step away, so
Okay.
he just went ahead and made me the host. So,
Okay. All right. Well,
thank you, brothers, for your participation tonight. It was definitely appreciated, and hopefully, you guys learned some tidbits in regards to the kidneys and how important they are. And yeah, feel free to reach out to either one of us should there be any questions.
Thank
All
you,
right.
guys.
Have a good
Thank
evening,
you,
guys.
Thank you.
Good night.
Good job, Doc.
All right.
Right.
Bye.